I'm a researcher at RTI Health Solutions, which is a division of RTI International, and I'm here to talk about a recent study we performed entitled Cost Utility of Aspirin and Proton Pump Inhibitors for Primary Prevention. This study was recently published in Archives of Internal Medicine. Essentially, we looked at the use of aspirin and proton pump inhibitors in the primary prevention in men with a range of Ph.D. and gastrointestinal bleeding risk. And we found that aspirin was found to be good value for money in these men, and adding a PPI seemed to be good value for money in men with high gastrointestinal bleeding risk. So let's go to the rationale for this study. Particularly, we know that aspirin has been shown to have benefits in terms of decreasing the risk of MI. However, we also know that aspirin has been shown to increase the risk of gastrointestinal bleeding. Acid suppressive therapy, on the other hand, has been shown to reduce the risk of upper GI bleed. So in this study, we looked at the cost effectiveness of aspirin with and without the use of proton pump inhibitors in primary coronary heart disease prevention in men with a range of CHD and GI bleed risk. Now, when we say cost effectiveness, essentially what we're examining is whether a treatment is good value for money. In particular, we're looking at the cost while on a treatment versus the effectiveness while being on that treatment. Essentially, we look at it in terms of a ratio where we have cost in the numerator and effectiveness in the denominator. Now, that effectiveness may be measured in several ways, such as life years, days without symptoms, response, whatever is appropriate for the condition. Now, when we look at two treatments, on the other hand, we look at what we call an incremental cost-effectiveness ratio. And here we've displayed the equation for an incremental cost-effectiveness ratio. Essentially, what we're looking at here is we're examining the difference in overall cost that would be incurred by a patient when on treatment A versus the overall cost that would be incurred by the patient when on treatment B, all over the denominator, which is the difference in effectiveness that would be incurred while on treatment A versus the effectiveness that would be incurred while on treatment B. So let's look at an example. Let's say a man has an incremental cost effectiveness ratio of $100. Essentially, what we're saying is that it would cost us $100 to gain one additional effectiveness measure. Let's say that effectiveness measure is a life year. So essentially we would be saying that it would cost us $100 to gain one additional life year if we were on treatment A versus treatment B. So in our study, we looked at a cost-utility analysis. Essentially, a cost-utility analysis is a cost-effectiveness analysis. However, the denominator or the effectiveness measure is a quality-adjusted life year. Now, treatment may extend a patient's life. However, a life year gained by one patient may be different than a life year gained by another patient. And so the quality gives us a way to capture that patient preference. So let's look at the calculation of a quality or a quality-adjusted life year. Here we see that essentially we're taking a life year and we're multiplying it by a utility measure. This utility measure captures the patient's preference for quality of life. It is a value between 0 and 1, where 1 represents perfect health and 0 represents death. So let's say, for example, we gain one additional life year by taking a treatment to prevent stroke. However, after I have that stroke, perhaps my life is not perfect, it's not a value of 1, but I may consider it a value of 0.8. So now I would take that 0.8 utility times that additional life year, and I'd have a value of 0.8 rather than 1 full life year. So now the question becomes, what is an acceptable cost-utility ratio to consider whether a treatment is good value for money? This is actually debated in the literature. However, in the U.S., we commonly think about $50,000 as being an acceptable threshold. This actually means that someone, a patient or a payer, would be willing to pay $50,000 in order to gain one additional quality adjusted life year. To perform this study, ideally we'd like to have head-to-head data where we have a variety of men with different CHD and GI bleeding risk. They would be on several different treatments, and we would follow them over the remainder of their lifetime, where we would collect both their cost and their outcomes. Then we would, for men on the particular treatments, compare their costs and outcomes over that time frame. However, a study of this type would be very costly in terms of time and money. So as a result, in this analysis, we actually used decision analytic techniques, which allows us to systematically and mathematically bring together the cost and outcomes without having to do that costly, time-consuming study. Specifically in our analysis, we developed a Markov model in which men are simulated through a variety of health states. And here we actually see a figure, our Markov model here, in which we have men entering into the healthy health state. They enter in this healthy health state in which they are put on one of three treatments, either aspirin alone, aspirin plus a PPI, or on no treatment. These men are then followed for the remainder of their lifetime, year after year. They may stay in this health state, or they may progress to have a cardiovascular event such as a myocardial infarction, a stroke, or angina. If they progress to one of these states, they incur the costs and outcomes associated with those health states, and then they progress onto a post-event health state in which we assume that they incur optimal secondary prevention, in which they incur greater cost and a greater risk of CHD mortality because of having the previous event, and lower utilities. Now, these healthy men also have a possibility of having a gastrointestinal bleed, so they may progress to the gastrointestinal bleeding health state, in which they enter the health state, incur the cost and outcomes associated with the gastrointestinal bleed. They then are taken off aspirin and then progress to the post-gastrointestinal bleed health state. These men are then followed through the model just like a healthy man. However, they are at increased risk of having a subsequent gastrointestinal bleed because of their history of the GI bleed. Now, men are followed through this model year after year for the remainder of their lifetime, and they can progress to death from any of the health states. And as they are followed, they enter in different health states. They incur the cost and utilities associated with each of the health states. So the comparators in the model we considered were aspirin, which is 80 milligrams per day, aspirin plus PPI, which was assumed to be 80 milligrams per day of aspirin, plus 20 milligrams per day of omeprazole, or no treatment. Patients were transitioned through the model with baseline risk of CHD events, which were estimated from the Framingham risk equations. We looked at several scenarios of men, three age groups, 45, 55, and 65 years of age. And we looked at 5, 10-year CHD risk ranging from 2.5 to 25%. Men also incurred a risk of GI bleed, which was obtained from the literature. We assigned the gastrointestinal bleeding risk based on their age, and as men went through the model, their gastrointestinal bleeding risk was allowed to increase. The treatment efficacy was measured in terms of relative risk, which were obtained from the published meta-analyses in clinical trials. And particularly for aspirin, aspirin had the effects of decreasing the risk of MI, decreasing the risk of CHD death. However, it was also associated with increasing the risk of combined stroke and increasing the risk of an upper gastrointestinal bleeding. Proton pump inhibitors, on the other hand, decrease the risk of upper gastrointestinal bleed, and we assumed they had no other adverse effects. And we assumed that these treatment effects were independent, and so they were additive. And then we also had the costs and utilities associated with each of the health states, which was obtained from the published literature. So let's look at the results. In the results, we took a base case man who was healthy with no history of CHD. He was middle-aged, age 45. He had a 10-year CHD risk of 10%, and his annual gastrointestinal bleeding risk was 8 per 10,000. So as a result, for this man, we saw that aspirin, for aspirin versus no treatment, we saw that aspirin was more effective and less costly than no treatment, meaning that men would gain more QALYs while on aspirin versus no treatment. When we added a PPI, combination treatment was found to be more effective. However, it was also more costly, and the incremental cost-effectiveness ratio was 447,000. When we examined the effects of changing the different 10-year CHD risk levels, aspirin was more effective and less costly as long as a man's CHD risk was above 5%. Adding a PPI, we saw that combination therapy just never achieved good value for money when compared to aspirin alone. And we saw similar patterns when we looked at the 55 and 65-year-old man. Shorter time horizons had no appreciable effects on aspirin versus no treatment, but the incremental cost-effectiveness ratio did increase when we compared the combination treatment of aspirin plus PPI to aspirin alone. We examined the effects of changes in the GI bleed risk because this was an important factor for the analysis. And in the 45-year-old man with the 10-year CHD risk of 10%, we saw that aspirin essentially remained cost-effectiveness or cost savings until the GI bleed risk was greater than 5%. Now, adding a PPI became cost-effective when the annual bleeding risk was about 4 per 1,000 and became cost of savings when the risk was 7 per 1,000. In a 55 and 65-year-old man, actually adding a PPI became cost-effective when the bleeding risk was as little as 2 to 3-fold above the baseline. And finally, we found that adding a PPI was more cost-effective in younger men because they received the cardiovascular benefits of aspirin for a longer period of time. And so overall, this analysis, this updated analysis, supports the use of aspirin for primary prevention in men with a variety of CHD and GI bleeding risks. And we see that the increased risk of GI bleeding doesn't really reduce the net benefit of aspirin unless the GI bleed risk is very high. We also saw that adding a PPI didn't appear to be good value for money in men with low to average GI bleed risks, but may be valuable for those men with a GI bleed risk of greater than 4 per 1,000 per year.